pain is it's an unpleasant sensory and emotional experience associated with actual potential tissue damage or described in terms of such. So particularly with acute pain, you'll have an associated injury, but chronic pain, it's often a malfunction of the neurological tree. And we generally talk about persistent pain being pain beyond pain continuing beyond what is expected time, which is generally around 3 months for most serious injuries. So chronic pain or persistent pain is a chronic pathological process, unclear onset, and continues on and on. Patients often look distressed and withdrawn without any significant neural changes, and it often is associated with mood disorder, anxiety, insomnia, and lie. You'll often see personality changes due to the constancy of the pain, and often partners will say they're not the person I started out with or I married. And if you can find an underlying disease or injury, you'll treat that, but otherwise you tend to try and manage it with not only physical input, but also psychological and social supportive care. When you contrast acute pain, there's usually a definable cause. It usually has a time frame. And you often see neurological and sympathetic changes within the body, racing heartbeat, racing breathing, higher blood pressure, sweating. And here you can often direct the treatment at the illness or injury causing the pain. So rheumatoid, you might look at targeting a joint. If you've got a cut or something, that'll be tidied up. So you can actually see and manage that acute situation. So the differences: acute is recent onset, expected to last a short time, and you expect full recovery. Whereas for ongoing pain, it persists for a greater than 3 months, and it's not one of cure, it's one of management for an expectation. But you can have other situations such as acute on chronic pain, recurrent acute pain, see migraines, for example. So sometimes you're trying to manage both. Remember the 3 areas in polio survival. We've got post-polio syndrome, which is really a muscular neurogenic decline, and then you have overuse injuries, and then late effects of polio, which is biomechanical pain. So joints wear out, tissues wear out because they've been taking on extra loads. Post-polio syndrome, your prime features are fatigue, pain, and weakness, and fatigue is really, really common. And I heard someone discussing about feeling really fatigued before we started the talk, and humidity will certainly impact upon you if you've got a background of fatigue. Occasionally, about a quarter of patients, you get new wasting, and then you have your regulars of heat and cold intolerance, and it's hard to pick who's got what. Obstructive sleep apnea, often due to the central neural problems, plus weight gain, problems with swallowing, problems with sleep. In 50% of post-polio syndrome patients, survivors have, 50% of survivors have symptoms of post-polio syndrome. The pain is generally neuromuscular in nature, burning, cramping, deep ache, often worse after activity at the end of the day because fatigue kicks in, particularly in the affected limbs. And the affected limbs, I mean, not only the polio limb, but the other limb that's compensating for it. You manage it by decreasing activity of the affected muscles and also adding orthotics for support. And there may be a role for simple analgesia and what we call neuromodulation, where you try and trick the nervous system into decreasing the pain outputs. In late effects of polio, we have biomechanical pain. It impacts upon both affected and non-affected limbs. It's generally due to postural malalignment or biomechanical dysfunction inequities, which have been going on for years and often leading to orthopedic discrepancies. You'll see overuse injuries, ergonomic inefficiencies, and this is on a background of someone who wants to be successful, but it's a little, the functional decline is a little greater than someone who's got the perfect human body because of all those other factors before. So you see functional deterioration with time and age. So in terms of late effects of polio management, you want to decrease stress on the joints and soft tissues. So realignment, improving biomechanics. So this will involve physio, orthotics, OT, modification of home and work. Don't go down the process of no pain, no gain. You need to balance it up. There might be some discomfort, but you don't want to overstress joints. And in fact, compared to when we first started working in the polio area, we now know that there are surgical options. So when I first started seeing polio survivors in the 1990s, there was minimal orthopedic surgery done for hips and knees and shoulders. Now with better techniques, better instrumentation and better anaesthetic management, with also awareness of what happens with a polio survivor, the option of surgical correction is a much more agreeable thing. So common sites for pain for polio survivors, so your muscles and your nerves, the overuse of muscles, tendons, you may get trochanteric bursitis or bursitis around the shoulder or elbow, and the feet and hands often have ligamentous issues. And common sites for pain are shoulders, elbows, hips and these are classic for having to weight bear and overuse in comparison to the affected limb. So the osteoarthritis, back, neck. So when I talk about back, I talk about the thoracic spine and the lumbar spine. Shoulders, hips, knees, hands and feet. You may see radiculopathies, and that's where you get pressure on the nerves as they rise out of the neck or the back. And sometimes you need surgical decompression for those. And then you can get nerve compression, such with carpal tunnel syndrome and ulnar nerve compression, particularly with your weight bearing through crutches, sticks, and frames where you're pushing down on your hand and wrist. So the nerves get trapped as they're passing through those areas. So pain, if you think about pain and its impact upon quality of life, it has an impact upon someone's physical well-being, someone's social well-being, psychological well-being and spiritual well-being. So it has ramifications in all aspects of a person and their well-being. And when we target managing pain, we need to have a holistic approach rather than just think about drugs or injections. So what can influence your pain or your perception of your pain? Negative influences include maladaptive treatment style, where people chase various hands-on therapists, maladaptive family support, so sometimes family will just throw their hands up and abandon you, and others will overdo things, so they enable. Work environment, any form of conflict, unrealistic expectations about what recovery is going to occur, and how people respond to life stressors. Now, if you can get to things early and adequately assess, treat and support, you get a better outcome. This often allows you to address the pain earlier. You want your therapist to be supportive, interactive, not necessarily enabling, but giving direction and support and structure for you. Having a holistic approach and understanding the situation, setting realistic goals and minimising stress for the person. So, comparing acute pain to persistent pain, acute pain, cure the illness causing the pain. Persistent pain, restore. You want to restore physical, psychological, social function and minimise distress. Symptom relief in acute pain, whereas you want to try and control the pain, management of pain so that you decrease the distress. So we'll do it. There's a diagram coming up a bit later called the onion, and you'll see what I mean by that when we talk about distress and pain. You can target the painful part in acute pain, but really persistent pain requires that whole person rehabilitation. You expect to return to your previous situation with acute pain, but adjustment and adaptation is necessary in a persistent pain situation. Often acute pain involves a patient having things done to them, whereas persistent pain involves a person participating and coping actively. You might have hands-on practitioner in acute pain, but we certainly don't look at hands-on. Your treatment team should be coaching you and assisting you in managing the situation. Analgesics are used to the level of the pain, whereas you tend to try and be a little bit more scheduled in the way you use analgesics in your treatments. You can basically use the medical model for acute pain, but you need a multidisciplinary team approach when you want to manage persistent pain. You have a short-term focus for acute pain, long-term focus for persistent pain. You may require rest in acute pain, but generally you want activity in persistent pain. Now, this is a really important slide because the concept of how you manage that chronic pain is so much different to what the medical model tells you. And you really don't want the medical model when you're handling a patient with persistent pain. So, stepped approach, address fears and encourage resumption of normal activities. You structure your interventions such as physical exercise to the person's needs, and you actually look at psychological support and management to help people move forward. There's a lot of brain training that occurs in the persistent pain process. So the principles of management are initial prevention, early detection and intervention, partnership with the team, have a goal-orientated, timely approach, and treat the situation with respect and dignity. We have a lot of practitioners who just roll their eyes and don't necessarily address the person's needs, and that doesn't help the situation at all. Multiple people involved. The most important person in the management of persistent or chronic pain is the person themselves, and then secondarily their family or carers, because they need to assist that person with the structure. And then you have a team of therapists who may assist, remembering that in the polio situation, the role of the orthotist is incredibly important, as is the role of the podiatrist, particularly with lower limb issues. If there are specific issues with swallowing or diet or such, you can refer speech therapists and dietitians. And if there are other medical issues, you may involve another form of physician. What's your goals? Improve patient understanding, improve physical functioning, modify the perceived level of pain and suffering, and that takes a lot of psychological management, put in place coping strategies for dealing with disability and distress, promote self-management, so that's what we want the person to take control of their situation, and address healthcare services issues. Sometimes if you're going to practitioners who don't quite understand what's happening with you, they can make the situation worse rather than improve the situation. So if there are known causes of pain, you can try and address these. You need to educate the patient in terms of how the pain's being assessed, what you're measuring, and evaluation. Remembering that pain is a subjective thing and it's the person's perception of the pain, not those around them who are actually going through the pain. You need to have clear goals for treatment and expectations associated with this. So it's not reasonable to think that someone's just who hasn't walked for more than 25 metres for 5 years to be able to go and walk 100 metres. You need to have reasonable goals. Look at the various options that can be utilised, and if there's a role for drugs in the short term is appropriate. But ultimately, it's about how the patient or person themselves manages in life, and you need to adapt it for them there. So it's good to have a pain diary when you're measuring your response to treatment. I often talk about over a 2-month period, writing down what you like. So you tend to forget what you were at the start of the process. So what's the severity of the pain? How does the pain behave you during the day? What makes it better or worse? How does it impact upon your sleep? Are you needing medication and when? And how does it influence your day-to-day functioning? From a therapy prescription, we talk about medical diagnosis, the precautions associated with what you're going to use for treatment, the goals that you set, the type of therapy you should put in place. And when we talk therapies, we're not just talking drugs, we're talking about principally day-to-day functioning approaches, how often you do your exercises and and how long for, and then you review your situation to make sure that things are on the improve. And this is once again where the diary comes into play. We know that pain can be reduced by altering the biomechanics to a more sensible approach, changing lifestyle, sort of saying looking at things and saying, is this really what you need to do now? Are there other things, or can you cut back on certain things? And adapting and adjusting your day-to-day activities to allow you to have the energy to do the things you want rather than the things you need to. Now, what I mean by that is that people were talking about fatigue before, and I think fatigue is probably the most disabling of all the symptoms in the polio survivor. So you need to be able to manage your fatigue in a way that you can enjoy your life and do the things that you find enjoyable, and find ways to do the things you need to do with support. So various therapy roles, we've got pain management, physical, cognitive and psychological, local measures such as heat, cold, ultrasound, TENS, massage, interferential, joint protection and stabilisation with orthotics and improving muscle control, stretching, range of motion, mobilisation, manipulation, orthotics and aids. These are all about adapting and adjusting a person's movements, structures, and trying to improve standing and walking tolerances and improving sitting tolerances by adapting the person's structure. They look at endurance activities, so gently build up, and I start at a lower load and increase slowly. Ergonomics and pacing is really, really important, particularly when fatigue is a compounding factor. Psychological support and counselling, because often people get quite despairing at the loss of their independence, and the other activities may be involved for certain people, like work hardening and work retraining, but you really need to focus on, as a usual process, the vocational activities, so the non-working activities that allow people enjoyment in life. Multiple treatment options, which are there. Basically, the medical model is limited in our persistent pain profile. So we're really looking at physical therapy, psychological therapy, lifestyle modification and adaptation with various equipment and orthotics. Here's the onion. So the onion is broken down to the smallest circle there is the nociception. So that's the stimulus for the pain, then the pain perception that comes from that, and then you have your distress and suffering associated with the pain, and then your pain behaviour. And in the acute phase, you're often only confronted with the nociception and pain. In the chronic phase, you tend to get more into the suffering and pain behaviour. So as you can see from the diagram there, that pain and nociception tend to be more about medical management, whereas suffering and pain behaviour require strategies, cognitive, psychological, physical and functional, to help people move forward in their lives. All right. I'm constantly confronted by the fact that the concept of orthotics is seen as a negative. It should not. It's meant about liberating a person. So why do we use orthotics? We want to decrease falls risk, protect joints, reduce pain, and improve gait speed and symmetry, and decrease fatigue. So they have a significant role for improving quality of life in appropriate situations. Sometimes orthotics are prescribed that are really not appropriate for a person, and you need an orthotist who hasn't just come out of university. You need an orthotist who actually understands the whole challenge of the polio survivor. So significant adjuvant in chronic persistent pain management is psychology. Because you're having psychology input doesn't mean that you're having a rebirthing experience. It's acknowledgement that the person's pain is there and it needs to be managed. And psychology, actually, contrary to the concept that the person is not being taken seriously, is actually taking things seriously, because when we introduce psychology for the management of the person, we are saying we need to put in place strategies to assist this person. There are multiple psychological treatments. Cognitive behavioural therapy is the most common and well validated, and within that there's a thing called acceptance therapy as well. Operant behavioural therapy, where you look at activities that address how a person responds to their pain. Self-hypnosis can be useful. Motivational interviewing, that's where you change a person's attitude towards things. Clearly, relaxation, particularly at the end of the day, assists, and guided imagery can be utilised as well. So if you look at the cognitive behavioural model of fear of movement, go back again. So where you have a painful experience and it catastrophises, you get into this circle of fear of movement, avoidance, more disability, disuse, depression, more pain, catastrophize, becomes a circle of never-ending style. What you want to do is get a person to be able to adapt to where they're at, so take away that catastrophic approach, address the issues that they're facing, and assist with rehabilitation and, to some extent, psychological recovery. Medications, as a rule, generally limited in what they offer, and as you're all aware, in a polio survivor, using medications that act centrally often has an increased risk of side effects. So simple analgesia, like paracetamol, short-term use of non-steroidal anti-inflammatory drugs like Celebrex, Mobic, they're the ones we tend to use now, and they're COX-2 inhibitors. Antidepressants can have a role not only for sleep and mood, but also pain, as do anti-seizure medications such as Lyrica and Neurontin. The commonest antidepressants that I'd prescribe would be either amitriptyline or Endep, or duloxetine or Cymbalta. And occasionally injections, local and systemic, for specific disorders are appropriate. And also, if there's an inflammatory component, occasionally a role for steroids, particularly with back issues. The other medications you tend to need to be very careful with. The centrally acting medications have, I believe, lower mood, make your fatigue worse. So you really should try and avoid them where possible. We'll probably have a few questions about medications a bit later that we'll try and address more specifically. You need to, if you are prescribing an analgesic, appropriate drug for the pain and its severity. We have a thing called an analgesic ladder that we may use. We try and use the antidepressants and anti-seizure medications for nerve pain. And I would never prescribe a placebo. That's like water or saline. I think that's a dishonest way of approaching things. Why do we regularly assess? Because we want to maximise functional well-being. We want to optimise pain relief. We want to minimise side effects of medications if we prescribe them. And we want to engender the best quality of life for the patient that can be achieved. A couple of things that we're still looking at. We know that because of the central sensitisation or the changes in the brain and the spinal cord associated with persistent pain, that there may be some roles for brain plasticity in improving things, and certainly psychology shows that with our cognitive behavioural therapy. So we're looking at trying to develop strategies through psychology to assist the way people perceive their pain. There is science, there's research being undertaken for psychoneuroimmunology of pain. It's sort of stalled a bit, but we certainly feel that that's an approach that should be addressed. We need to look at psychosocial factors in their way that they affect the mind-body connection. And we know also that the way the brain perceives things can impact upon disease susceptibility and progression. All right, so to finish up, so that's about half an hour, that's not bad. If possible, to find the cause of the pain, then you can target a treatment. But generally, you can't always find the cause of pain, so you need to address the situation for the person, understanding, particularly in the polio survivor, the sequelae of polio, looking at preventative activities, appropriate interventional treatments when undertaken, but really modifying lifestyles for the best outcomes. You want to try and reduce the pain and get a person back to their previous role if possible, improve function, and use the least amount of resources as necessary. You want to stop people doctor shopping because you'll get mixed messages that way. The ultimate goal is to manage the pain and improve quality of life. And I think that's it. So I'll get rid of that.